students, and welcome to this next case discussion and video on a C-section which I'm doing on a second gravida. Previous one C-section done outside at 4 years back for fetal distress. This time she came to me, she was under my antenatal care, and she came to me with decreased fetal movements, and I decided to take her up for C-section at 37 plus 4 weeks. And previous C-section which I encased, which I showed to you, was on a vertical incision on the skin. So obviously every movement, every problem that you can face by a vertical skin incision was told to you in detail. How to enter the abdomen, how to take out the scar, how to give traction, what things to do, what things not to do. And this time I'm deliberately telling you a previous transverse skin incision, so that you now understand the problems which you can have with a transverse skin incision, which you will find more in your practice. Very few people now give a vertical skin incision. It was done by a surgeon outside. It was a horrible case. The last case, which some of you were there for the workshop, some of you had asked for a recorded section. Some of you might still be interested, so let me know. Now I have kind of compiled a few cases together, and I'm giving it case by case as a C-section workshop. So anyways, let's not waste any further time. Let's start with the case, and let's see how what is the problem that we can face in a transverse scar. So after checking for the spinal anesthesia, whether it's right or not, taking the permission from the anesthetist, I start by giving a transverse. Now this what I'm doing here is I'm delineating the previous scar, because it was a little hyperplastic, it was a little fibrosed, it was a little kind of keloidic in nature. So I'm trying to remove the previous scar. My assistant, they're holding the previous scar with these Alice forceps, and now I'll just remove it with the help of a scissor, a curved scissor. The bleeding points that you can see over here, I'm asking my assistant to not dab on dry, to press upon it. Okay, so all these little oozers which you will see, if you press properly, they'll all just go. Through the pressure, the small oozers, they will quieten down. Now have a look at my hand here. I'm stretching the skin so that I don't give a puckered skin incision, I don't give a puckered internal incisions. They are all just bold, straight, proper incisions. See, have a look at my hand movement. No shaking, no tilting, nothing. And once I have stabilized and I've stretched the skin, I usually do it with my own hand. I don't ask the assistant to do it. So here you can see the subcutaneous fat, the subcutaneous fascia. This white structure over here is the rectus sheath. And see, I'm asking her to press on it. And the rectus sheath is highly fibrosed. Now my assistant can be seen holding the rectus sheath. And over here, I'd like to pause here, because I'd like to tell you something specific about a previous C-section. See, over here, what you can see is the upper leaf of rectus sheath, the lower leaf of rectus sheath. My next case is on a primary gravida, and the ease with which you can remove and you can do a blunt dissection on the rectus sheath, so that you can separate the rectus sheath and make space over here. It is very, very difficult in a previous C-section to do that step. Some of them are very nicely done, and you can easily work your way through, but this one was specifically bad. It was highly fibrosed, and the rectus sheath was not properly giving way. This is the rectus sheath, see, and it is right above the muscle layer. It was smudged with the muscle layer. So what I'll do is that I will do I'm trying to separate the muscle underneath, but I'm not successful. So I decide to do a very superficial, proper, sharp dissection and try to incise the rectus sheath, so that automatically the muscles get separated. But the muscles will not get separated so easily. So anyways, I've just incised the rectus sheath. Okay, the muscles are still adherent to it. So the adherent muscles have just gone down. All that has happened is just that they've gone down. They have not separated yet. Maybe this side it will be a little better. See, have a look. So again, I'm doing the same. Look at the movement of the scalpel. It's beautiful, it is very superficial, it's very gentle, and I'm not doing any. Now see, this is called the blunt movement. I'll explain it to you furthermore when I will describe the primigravida case, because it's so nicely shown in that. This is the upper sheath of rectus, this is the lower rectus sheath. What am I doing over here? Again, let's pause and let's see. What I'm trying to do over here is, again, see, this is a muscle belly. All this is the rectus abdominis muscle, which is, stuck on, because it's a previous section, it's stuck on to the rectus sheath. And maybe, part of peritoneum is also stuck. So you have to be very, very careful when you're doing this step. It looks very easy, but it's not a very simple step. So you have to be very gentle. What I'm doing over here is basically my actual work is being done by these two rectus, this Alice forceps, which are pulling this fascia up. So they will do the blunt dissection. Okay, the pulling force will give a shearing force. The shearing effect will probably make space, which I want over here. And this gentle, what I'm doing over here with the scalpel is just gentle, ease of my scalpel on the fascia here to just let this pulling take place. So let's go forward and let's see what happens. Very gentle strokes of scalpel, because it's such a sharp instrument. I'm scared over here for any perforators, for any oozers, for any muscle belly giving way, because muscle bleed is very bad. It doesn't quieten down with cautery, doesn't respond well to pressure. It just listens by unnecessary sutures, so you keep giving sutures then. Again, very gentle movement of the scalpel. Also be very careful while putting the knife back, because all your assistants are busy helping you and you are putting the knife right at a place where they are working and they're using their hands. Now this is the lower rectus sheath. Again, very gentle, superficial strokes, beautiful, strokes which are not deep, just sufficient to make it easy for them to pull. The fascia which is clinging on the rectus sheath, I'm just trying to, kind of separate it slowly. And this is, yes, I'm trying to, still not happy with the space, so I'm trying to use blunt force, because here I'm finding some space, which I did not find this side. Now, I'm now holding the muscle belly. See, I like to stress something over here. See, this is, so over here, have a look at this rectus belly. This place is where I'm holding my Alice forceps, and I asked my assistant to hold this part of the rectus belly, but she was trying to hold somewhere in between. So what do I do with this? Now I try to move, see, I try to give some traction over here, so that now why am I giving the traction over here is because I want to pull the peritoneum up, so that anything from below, maybe the intestines or the omentum, or sometimes even the bladder, sometimes even uterus, is stuck directly under the peritoneum. This was a wrong movement. Wrong movement in the sense I was just giving traction, so the muscle belly sometimes gives way. Again, muscle bleed is very bad, so be very, very gentle. I'm asking my assistant not to help me here, because she cannot do anything. If she gives more force, it will be more harm than good. I'm trying to make space for me to find a clean spot for me to enter the abdomen here. It's smudged, it's totally smudged. Everything is like, the peritoneum is stuck on to the rectus, to the muscle, to the rectus sheath, everything. And finally, very small window I've got over here where I could see a clear peritoneum. I could see that there is nothing, underlying it. There is no gut, there is no bladder, there is no omentum. I finally found a very, very clean space, and I'm asking my assistant to hold it, and then I give a nick to find a window. And finally I got my window. See, this is the window. Beautiful. And this becomes my peephole to see inside the abdomen. What I do is I ask to remove everything. I'll put my own fingers, go inside, see properly if there is anything clinging on over here, if there is any intestine, any omentum, anything. It's an abdomen, anything can be clinging on over here. Any abnormality can be there. And then I see, now I'm seeing here as well. So I'm watching everything properly, and then I stretch. Why I stretch over here is because I already know that I've cut at 2 points where there is nothing to be feared of. So I'm cutting and I'm I'm not still happy with the space. I need sufficient space to move my hand properly and for the baby to be delivered out properly. So I do this, and now look at this movement. This movement is called, putting the uterus back, rotating the uterus, fixing the uterus. Uterus is usually dextro rotated, you know that, right? So if I do not correct this dextro rotation, I might give an incision at the wrong place and it will extend to most probably the left angle. The uterine artery might get torn. So I have to correct the uterine position, put it in the right place, ask the assistant to stabilize the uterus. It should not come back now. Once she's hold it, it should not come back now. Then I'll pull up the uterus, and since I've pulled up the uterus, I can't go very low in giving the incision now. Okay, so I'll pull up the uterus, I'll try to nick the UV fold, put it down, and then give an incision in the UV fold. So I'm in the lower segment. So I start here. I'm pulling the, she has stabilized the, I'm asking my assistant to stabilize the uterus. She has stabilized the uterus, and now my attention will go on the lower segment. I'll try to, yes, see, this is called pulling the uterus, the lower segment above. So automatically I'm now searching for the UV fold. I'm now not going down because I'm very scared of going too down, too below, because I've pulled the uterus up. I'm not happy with the UV fold. I don't think that it's proper UV fold, and here I take the decision of not pushing the bladder down, to give the incision at that particular place. And with this I finish the first part. Those of you who want to get the remaining parts of this C-section, please inbox me, please WhatsApp me. I would love to help you. This entire process is actually designed to help students like you. So please approach me, and do not hesitate. The ones who've already subscribed to my classes, I'll be updating and uploading more of those videos. So just stay tuned. Thank you everybody. Bye bye.